All right, well, I think we'll go ahead and get started with the post-break presentation. I want to begin by also thanking OIS, especially thanking all of you for being here. It's one of our exciting programs. I think someone said it perfectly earlier on when they said, where would we be without OIS, 13 years later, and I couldn't agree more. They've always been extremely visionary. They've tied in industry, ophthalmology, optometry, eye care, and investors. Very few entities have ever been able to achieve it at the level they have. So I'm Paul Karpecki. I practice in Lexington, Kentucky. I have one of the largest advanced dry eye clinics. There's other large ones there, but mine is very atypical because it's a 100% referral center. I think pretty busy dry eye clinics have about 30 to 50 Sjogren's syndrome patients. I have over 900 under my care. Very similar to graft versus host disease patients, really a disproportionate number. So my clinic's quite unique in that sense, but I think it all fits in dry eye. So I'm not the expert when it comes to primary eye care, and we have some experts there, but I'm going to take you through a little bit of this understanding of where we're at. And kind of what I learned over 25 years. Hard to believe that I started my first dedicated dry eye clinic 25 years ago in 2024, which we're pretty close to. And I think back to it wasn't like I knew this was the future. In fact, when I was working in Kansas City after doing a cornea fellowship under Dan Dury, who was a top cornea guy, trained Vance Thompson and many of us back then, there was only one job left, and it was to run the dry eye clinic. It was either that or no job. So I thought, well, I'll take what's there. And then here we are 25 years later talking about it at OIS presentations and realizing there's 44 million people in the United States who have this. This is based on 2023 data if you extrapolate it out. It's a pretty large number. We are pretty good at diagnosing it, but not great. 18 million people are diagnosed per year out of 44 million. And I know you've seen the statistic, but only 1.3 million people are treated. How could we have a disconnect where we treat 1 in 40 people who have dry eye with therapeutics? Now, we're doing more on OTC, but those aren't technically treatments. Some of those are lubricants, and we have a real need. I mean, I could almost stop on this slide and say, do you think we have a need for more therapeutics, more targeted, more devices, more of the future? And this slide would tell us, yes, we have to treat the other 39 out of 40 people who have dry eye disease with one of those, and we're not doing it. And why is that? Part of the reason is I think doctors do think it's complicated when something like dry eye should be easy. We also have people who think it's really easy, like chapped lips, something you could just take care of in the moment. And people who suffer from dry eye get so frustrated by others who say things like that. How can you miss work? Why don't you just put some lubricants in? There's many similar conditions. There's no magic bullet. And this is where payers have a real problem too. Imagine being in cardiology and someone saying, we can't put you on a statin because you have to fail on ibuprofen or an NSAID. And that's what we're doing right now. We're saying you have to fail on an immune modulator, an anti-inflammatory before we can actually start on something that works on the disease. So they're not addressing that. We're not really been addressing the causes until new things now that are addressing meibomian gland dysfunction, Demodex blepharitis. We're finally there. And the future goes way beyond that. It's repair. It's targeted. It's devices that work within it. And it's figuring out which medications work the best for each condition. And boy, does it ever pale. 44 million people in the U.S., there's somewhere around between 1 and 3.5 billion people worldwide who have dry eye. And I know that's a big range, but that's what the research shows. It has a range between about 1 billion and 3.5 billion. And if we were to ask questions like, do your eyes feel irritated? How do they feel? How do they look? Do you experience fluctuating vision? Do you have the urge to use artificial tears? And how much time do you spend on digital devices? That number would far exceed 44 million in the United States. We're still not uncovering half of what's there. And unless you think digital devices are disappearing, these numbers are going to expand on a regular basis beyond this. So I think part of the reason it doesn't necessarily get the credit it could get is something that was mentioned earlier today, and that people don't go blind from this. It's sight-threatening complications are rare. I've seen a fair number, but they're rare. Quality of effects, though, are dramatic. Studies have shown that people with dry eye suffer more than people who have a hip fracture or people with severe chronic heart pain or angina. So we really have to start understanding it. And we know the etiologies are not going to decrease. They're only going to increase over the next few decades. We have better ways of diagnosing. If you look at TFOS, DEWS-2 methodologies, we are getting better. Mark Twain had one of the best quotes ever. He said, if I had more time, I'd have written a shorter letter. And I love that quote because when I started my dry clinic, I wrote the long letter. I did every test you could think of, from Schirmer's to fluorescein and lissamine, and measuring everything we had. And today, we really simplify it. My average dry eye exam takes about 3 minutes. And that's the time I spend even with follow-up patients, new patients a little bit longer, where we glance at the breakup time, check osmolarity beforehand that's done with us, use non-invasive testing, look at the tear meniscus height, look where the staining is, and express the oil glands. So with that, we're able to kind of differentiate the type of dry eye disease. You wonder, why do we put this in here? Because if we don't even take the steps to know what the type of dry eye disease is, we can't actually apply the right therapeutics to help these patients do well. While inflammation is universal amongst dry eye, the minute you have homeostasis loss, you're going to have an inflammatory response. The facts are, we got to get away from just treating the inflammation and starting to treat the cause for the inflammation. And that's the only way we can achieve really good success. And you look at some of the people on the panel today, you know, as we, obviously, Dr. Ketting and Dr. Adele, Dr. Bowden, who've had great successful dry eye clinics, have understood this for a long period of time. But you have to find out if the oil glands are normal. You know, I get this question a lot from doctors because it's kind of new to have to express an oil gland, which is such an easy 3-second thing to do. You don't need anesthetic. But people will say, Dr. Paul, I'd love to get more into dry eye, but do I really have to express the oil glands? 86% of dry eye involves some level of meibomian gland dysfunction. That's like saying, I want to manage macular disease, but do I really have to look at the macula? Yeah, you have to look at what's going on. And doctors are starting to recognize the importance of doing these little things to get a lot further, and we're going to get to a much higher level of diagnosis. But summary of a diagnostic summary today, including TFOS DUES 2, which is backed by 770 references. That was the committee I was on. Yes, you have certain questionnaires for symptoms. You look for some dry eye by either staining, tear breakup time, or osmolarity, and then you subtype the disease. And then based on that, now there's a few nuances. I mean, there are other conditions. You got to look at eyelids closely to see if there's telangiectasia, capped glands. You have to have patients look down, looking for any sort of collarettes or blepharitis, such as Demodex. You have to express to see what oil glands look like. Sometimes you even have to check to see if their eyes don't close at night. It's a really big culprit for non-responsive dry eye disease by seeing if their eyes have a little opening at nighttime, which is incredibly common. And then once you know the disease, you've got to find the algorithms for it. And I'm always surprised. We've applied a little bit of AI to some of the algorithms that I've been working on for the last couple decades, and I realize, wow, based on those results, I've been teaching something terribly wrong for the last 10 years. Things come out that you don't expect. But if you think about the disease, you've got a lot of components. The reason I put this slide in is because the question was, do we have need for more therapeutics when we've got all these new drugs that are coming out where we're at? Well, if you look at evaporative dry eye, you still have to treat the obstructed glands. These are where devices come in that we'll hear about as well as medications. You have to treat blepharitis. That's there in, according to Hank Perry's study, 94% of all evaporative dry eye has some sort of biofilm or microbial component. You have to treat the inflammation, which is universal in dry eye. And of course, for years, we've only been treating the tear film and then a little bit into the inflammation. And now with new drugs, we're getting into the meibomian gland dysfunction and the blepharitis. For aqueous deficient dry eye, we have ITV, inflammation, tear volume. New developments like punctal plugs, like we heard about or we're going to hear earlier today, really help greatly in getting the tear volume up. Yet I might not use a punctal plug if I had a bad case of rosacea with terrible telangiectasia, inflammation, and completely obstructed glands, which is your evaporative form. So you've got to understand where things fit. Mucin deficient, your vitamin A's, other components play a key role here. IL-7, 17s, others that'll come you'll hear about will play a key role in this kind of disease. And then the exposure keratitis. This is the #1 cause of non-responsive dry eye in my clinic. It's just a case where people's eyes don't close at night. And yes, they get MGD, and yes, they get blepharitis, but you've got to target that component to have any chance of succeeding in the other aspects of it. So the answer is treatments are still needed. We've targeted inflammation for the last 19 or 20 years. We then progressed to biologics, autologous serum, amniotic membrane, other things, cytokine extracts, et cetera. Now we're finally targeting evaporation, which is a cause of a lot of dry eye. We're targeting blepharitis with the new drugs that have been approved there. But the future is much more specific. We've got to get to, and I'll take Dr. Cherny's a quote from him that I learned as we were talking about things, is how psoriasis, for example, in dermatology went from steroids, which is kind of anti-inflammatories we've used in dry eyes for years. When I started my clinic 25 years ago, we were using steroids and artificial tears. Steroids were very periodic, and then we'd plug them. That was it, and wondered why we couldn't get a lot of success. Then dermatology went on to something much more targeted, your Sotoicus, your others, drugs like that, and then continued to addressing the cause. You have to have things that target repair, reversal, collagen repair. All of that will play a huge role in where the future is, and devices, as I talked about, are going to be essential to the success. Patients who have hyperosmolarity issues affect everything we do. They affect our outcomes when it comes to cataract surgery. Look at the number of dissatisfied patients who had high osmolarity or dry eye. 2.5% in the normal osmolarity group, 17.1% that didn't. How's that not going to give you good results? No matter how good your surgery is, cataracts, refractive. The number one cause for a contact lens dropout is dry eye disease. The number one cause for remakes for optometrists to do a lot of the primary eye care, like spectacles, is dry eye disease. So if you think about the burden that this causes and the impact it has when we don't look for the disease for osmolarity and other factors, and we realize very quickly that we have a need for much better diagnostics. We have a need for our utilization of really good diagnostics like osmolarity and other things we already have. We have a need for targeting that to where the future is, and especially we have a need for treatment. Treatment has to be comprehensive. The days of saying, okay, I'm going to start you with something that addresses your obstructed meibomian glands, like a compress or a drop, and then next time you come in, I'm going to add in your blepharitis treatment, and the next time you come in, I'm going to work on the tears, which I did a little earlier, and then patients are not going to come back. You have to be comprehensive, not stepwise, even though you cover all areas. Inflammation's still going to play a role, but if you don't address the reason for the dry eye, which these new therapies are going to be addressing, and 2 new ones recently are specifically addressing, you're not going to get very far because you're always treating the downstream inflammation without addressing what we have to take care of. Treatment has to be directed at the cause, not just inflammation, and not all treatments work in every type of dry eye disease. When I started looking at some of the information coming back in AI and some of our algorithms, I was shocked. Patients I thought this has to work on didn't, and others that had a little nuance different where it really worked in well, and there's much more to it beyond that. There's no magic bullet. There's multiple therapies and devices are required for treating this disease, and only when we start to innovate, like you're going to hear about with the next panel, will we start addressing the other 39 out of 40 people in the United States who suffer from dry eye disease. We are treating 1 million, 1.3 million with billion-dollar drugs, and yet 42.7 million people are still needing treatment in the United States. We have to communicate well, we have to portray this, we have to understand it, and then ultimately, we're going to have some good results. But this is a very, very common condition, perhaps one of the most common, frequent conditions we face as ophthalmologists and optometrists. Etiologies are known, but they're multifactorial and they're increasing. People spend more time on digital devices than ever at a younger age. Diagnosis has to be simplified, treatments must be stepwise approach, and these are more questions for the ophthalmic panel that'll come up, the optometry, ophthalmology crew that are specialists in dry eyes. But this is a vision condition, make no mistake about it. It affects everything we do in practice, everything from driving to surgical outcomes to contact lenses to spectacles to quality of life. 44 million people in the US, 3.5 million people worldwide need the knowledge that gets shared at OIS. They need new innovation that you'll get to hear about, and they need access to experts, and we'll have a panel who will discuss that as well.